Hi folks, welcome to a thrilling new episode of the Medical Device Cybersecurity Podcast. Today we welcome Adam Shostack to tell us more about threat modeling for medical devices. Apart from writing just 2 books in threat modeling, Adam played a key role in the development of the playbook for threat modeling of medical devices from MITRE, which I have right there, and he's extremely qualified to talk about the topics of cybersecurity and medical devices. You'll see just now.
Adam, welcome to the podcast.
Great to be here.
Wonderful. Adam, to introduce yourself, can you tell us a bit more about how you found medical device in threat modeling? How did threat modeling come to your life?
So threat modeling came into my life in sort of 2 stages. In ancient history, in 1999, Bruce Schneier and I wrote a paper on threat modeling for smart cards. And the way we did it was we talked on the phone and we thought about what threats existed to smart cards and we wrote a paper about it. Fast forward a few years, I had joined Microsoft. I was on the security development lifecycle team, and on my first day on the job, my boss came to me and said, "This threat modeling thing isn't working the way we want it to. Please fix it." And I said, "What do you mean?" And he said, "Well, it's not working." And I said, "Well, what does working look like to you?" And he said, "I don't know, figure that out and then let us know." And so I said, okay. And I realized very quickly that I couldn't threat model Windows or each new feature in Windows the way Bruce and I had threat modeled, right? We had to create a system which was accessible to people other than security experts. And so that second phase in my journey was, how do we scale this? How do we make it accessible? How do we teach it? And so I did that. I built some tooling. I created a card game. I wrote a book. When I left Microsoft 2014 or so, people started calling me and said, "Hey, can you help us?" One of the people who called was some old colleagues from MITRE who were helping FDA, and they said, "Could you talk to Dr. Suzanne Schwartz about this and other folks as well, Seth Carmody?" And so I did. And we spent a lot of time on the question of how do we scale this to the medical device industry? How do we make it accessible? And so, another stage of my journey was partnering up with MITRE and with MDIC, the Medical Devices Innovation Consortium, to do some boot camps, to do a playbook. There are medical device companies, as you know, as your audience knows, but as I learned, everything from a couple of people up to multinational conglomerates. How do we help all of them? How do we get these messages out to the community? How do we empower the community? This has all been really a fascinating journey for me, and I'm excited to share it with your listeners.
Oh, wonderful. Yeah, what a journey it's been since 99 thinking about security. It was quite unique back then to start thinking about this kind of.
It certainly was. And I absolutely want to give a lot of credit to various colleagues who I've worked with over the years, Billy Rios, Kevin Fu, Jay Radcliffe. I was blanking on Jay's name for just a second, who really did great work on introducing the idea that there could be vulnerabilities, who dealt with questions like, why would anyone do this? It's been a journey for this sector.
Yeah, absolutely. But just so we can understand a bit more about threat modeling, what it needs and what it's for, why do we even need it in the first place? What does it bring to the table?
So there's a great quote from Frank Lloyd Wright, who said, "You can fix it on the drawing board with an eraser, or you can fix it on the job site with a jackhammer." He was, yes. Yeah, he really meant the drawing board and the job site and jackhammers. And when we build devices, the choices that we make are not literally set in concrete, but the earlier we're thinking about security, the earlier we can make trade-offs. Do we want a wired interface or a wireless one? Do we want to use NFC or Bluetooth or Wi-Fi? those choices have security implications. And so if we ignore those security implications in the early days, or if we're afraid of those security questions, where like people might say, I'm not a security expert, I don't know how to make these decisions. That's where threat modeling comes in. And that's why we do it. And ideally, that's why we do it as early as possible in the product life cycle, so that we can address the questions with an eraser rather than with a jackhammer, or rather than with throwing away a year of development by a development team because the choices they made don't support the security needs that our customers have, that our patients have.
Yeah, makes sense to me. But, when you're pointing out to the drawing board when we're making the plans for a product that we're going to build, does it mean that threat modeling is a step, or is it more of a process?
When I think about a quality system, we need to have a step in which we engage with threat modeling. But threat modeling can be really simple, right? At the essence of it are 4 simple questions. What are we working on? What can go wrong? What are we going to do about it? Did we do a good job? We can ask those at the level of a device, and that device can be something simple, like a blood glucose monitor, or something complicated, like a CT machine, which might have multiple computers in it as part of a system. We can say, what are we working on and what can go wrong for each of those? We could also say that for a single feature. So let's say we developed our glucose monitor years ago and we want to add Bluetooth. We can ask, what can go wrong with the addition of Bluetooth? And so I really encourage people to think about what can go wrong as they're designing each feature. And, I work with people both in and out of the medical device world. And in the agile world, where we're shipping in cloud, the stuff doesn't matter in the same way, we can say threat model every story. In the medical device world, there's a little bit more design work. There's a little bit more, what are we going to build before we build it? And I work with a lot of device makers, and it's sort of like hospitals. There's the expression, if you've seen one hospital, you've seen one hospital. If you've seen one device maker's approach to building products, you've seen one device maker's approach to building products. But the big successful ones have all developed these approaches over years. And so I don't want to come in, and I'm going to loop back to your question right now. I don't have a preference of calling it a step or a process, right? If, just for example purposes, right, if Johnson & Johnson answers that question one way and Baxter answers it another, and Medtronic answers it a third way, I'm good with that. What I care about is that people find the right time in the way they deliver value to patients, really to patients. If they want to put it in and list it as a step, good for them. If they want to put it in and list it as a methodology, good for them. A value that we get from the 4-question framework is you can answer these questions differently based on what it is that you're working on, and you can integrate them. And there's a lot of approaches to risk management, right? Each device maker manages risk a little bit differently. We've got things like TR57 that tell you how to integrate this in, or now 97, excuse me, old habits die hard. My hope when I work with executives, is that we look at this as an enabler so that engineers can make good decisions when those decisions are difficult. And when I say good decisions, let me actually get a little more specific. Engineers can incorporate security into their thinking as they're doing design, as they're making trade-offs, as they're saying, we could solve this problem like this or like that, they can consider the security implications of those choices. When that's hard, and there are trade-offs to be made that involve risk or cost of goods sold or usability, we can use threat modeling. We can use the question, what can go wrong, to get more people involved, right? We can get a medical officer involved. We can get a product manager involved. We can get support involved, and we can have the conversation, hey, I'm concerned that this thing could go wrong. The answer is not obvious, right? For some things, the answers are sort of clear, right? Use TLS, make sure your product doesn't run as root or administrator. There are other things, a lot of them around usability, that can be hard. And especially as we go from a device like a CT machine, where the staff is trained and certified in its use, and we go to devices that are being used at home, usability really becomes important. We have to make sure that we don't inhibit security, or we don't inhibit usability to get security and end up with the patients not being able to use their devices to get the medical care, quality of life enhancements that they're looking for.
Right, absolutely. It's something to think about, regarding all the people that have to be involved within threat modeling, because, as you said, the threat can come from anywhere, and involving different staff members can be very helpful. So, does that mean that while doing threat modeling, you have to start questioning as well, not just people from within the medical device manufacturers, but also perhaps interview as well the people in the hospitals that could be using this tool? What's draw the line here on the information required?
This is a great question, and it's why I focus threat modeling on the 4 questions. Right? If you're making a medical device, you ought to be talking to your customers. I don't want to say that you have to do that in threat modeling, because then the cost of threat modeling goes up and everyone gets annoyed at me. If you want to be annoyed at me, you want to blame it all on me, go for it. But I think you need to have people who understand your customer in the room with you as you're thinking about design. And a colleague of mine, actually, I was honored to write the foreword for a book by Heidi Trost. Heidi just wrote a book titled Human-Centered Security. And one of the big messages that I love in her book is the importance of having a team that incorporates both security and usability engaged with people building the product. And the reason I love this is because sometimes security and usability end up in tension, right? And the best example, the easy example of this is multi-factor authentication. It slows things down, and it's important at a lot of times. If you just ask the usability people, they'll say take it out. If you just ask the security people, they'll say require it all the time. And if the product team is in the middle, having one security review or one security engagement and one usability review, and they get recommendations from each of those specialties, then they have to work it out all by themselves. But if you bring a team approach, and this is what Heidi advocates and why I liked her book so much, and it goes back to your question of, do you need the people who have talked to the hospital in the room? Yeah, you probably do. And I don't want that cost to be associated with threat modeling. I want it to be associated with product development, because threat modeling has this reputation of being a big, heavyweight thing that can be hard to do. And the more we layer onto it, the more it acquires that reputation. And that makes it hard to get to the benefit. And that leaves me unhappy.
This threat modeling accumulates a lot of the expense without necessarily getting all the hype it deserved for the benefit. Of course. Adam, let's we walk down the 4 steps. So we said, what are we working on? Usually you involve diagrams. Is that just what's required for the piece of what are we working on?
So I think a picture is worth 1,000 words. Drawing a diagram is incredibly helpful for literally getting everyone on the same page. Data flow diagrams are associated with threat modeling because threats tend to follow data. In the FDA's world, they are now looking to see diagrams like a multi-patient harm view, like a system update view. If you don't draw these early, maybe you're missing the opportunity to make them work elegantly or well, and you draw them late and it's challenging. You know, I was working with an organization recently. They're outside of the medical device space, but they're having some problems, and the architecture diagrams that they're sending me to explain what's going on as I'm onboarding into helping them are from 2018. Right? They haven't been kept up to date. And one of the challenges that we're facing in this conversation is people have different views of the system. There's the old story of the blind people and the elephant, where one touches the tail and says it's a snake, one touches the leg and says it's a tree, and everyone has a different view of what it is. And when we put it into a diagram of some form, and this can be really simple, and I want to emphasize how simple it can be. I will often start with literally the back of an envelope. I will start with a whiteboard, and we get a lot of value. The reason that engineers use whiteboards is they're great communication tools. And then going from a whiteboard diagram to a diagram that you're happy to send to FDA and get reviewed, that can be 10x the effort, right? An hour of whiteboarding can be 10 hours of Visioing or draw.ioing or what have you. Thinking about how to get to it quickly is important because there's only so much time in the day.
And there brings many benefits around what you're working on with next to the product. So we said, what are we working on? What's next?
What can go wrong?
So what can go wrong? How do we go about this question?
So honestly, I like to start with a very complicated technique, which is asking what can go wrong and getting everyone's answers. It is all over the map. People are scared. Like, I remember one meeting I was in, and I remember this very, very vividly. I turned to someone and I said, what do you think can go wrong? And he literally started shaking because he's sitting there in front of a bunch of security experts and he thinks his answer needs to be some deep security thing. And it wasn't. But he was worried that the battery pack on the back of a thing wasn't really well secured because they were trying to make it lighter and smaller, and so they had shrunk the little clip. And he said, the thing I'm most worried about is that old people will have trouble doing this. And I thought that was a great answer. But he thought that I was going to judge him for not having something like, well, there could be a buffer overflow in this interface. And so it's important for people to make room for all of these opinions. And a threat modeling meeting where we're potentially bringing together an interdisciplinary team start with a very open round of what are you most worried about. And if we set that up in a inviting way, where we say, your answer is whatever you're most worried about and no one's judging you for it, you get interesting things on the table, and that's valuable. We can proceed from there to use techniques like stride or kill chains, which are covered in the MDIC MITRE Shostack Associates playbook. There are kill chains like MITRE ATT&CK or MITRE EMBED, which have much more specific steps. I think both stride and kill chains have an advantage that they give you a structure which you can fill in that trees don't give you. The advice with a tree is pick a goal for the attacker and figure out how they're going to do it, and then expand or combine nodes. Well, how do I do that?
It's hard to become an attacker, right? Try to think like an attacker.
Potentially, and that's really hard. And a lot of people are not comfortable doing that. They're like, I'm a good person. Why would someone do this?
Especially with medical devices.
Yeah.
Like that they...
But as hard as this is to come to grips with, we see this explosion of ransomware against hospitals, but we don't have to get into being our attackers' psychologists to think about the question of what can go wrong, right? Stride, someone can spoof, is a perfectly valid statement. Someone can deliver an attack using it, and this is the stage of the kill chain. We don't have to get specific about it. We can say, hey, we're building a resilient device here. It should deal with this problem. And I think that's highly important because it lets us focus in on here's what can go wrong, and that leads us to what are we going to do about it.
Please tell us, what are we going to do about it?
Well, sometimes we're going to change the design. Sometimes we're going to add security code. Right, so if what we're building is an API for our device, we're going to make sure it has authentication, and the arguments to the API include the authentication field. Right? Sometimes we're going to lock down the S3 bucket in the cloud. Sometimes it's harder. Sometimes it's more of a trade-off. We're going to require that the user of the CT scanner once a month make sure that the CT scanner has been rebooted as an operational procedure that's in the user manual. Now we need documentation in the room with us. We're going to make sure that your device has an update mechanism so that when security problems are discovered, you can deliver the updates that the device needs to remain secure. And so there's a wide range of ways in which we might do something about that. And again, and this is really important, threat modeling is where we take the step back. We see the forest, not the trees, and we say, is this device designed well all up? A lot of people look at this, and some of the older risk management methods say, you should find the problem, you should quantify the risk, and that's really hard. And then you should add compensating controls to reduce the risk. Well, honestly, sometimes you can put the compensating control in and not worry about residual risk. For example, let's say I have an old Unix, I'm working in a classical Unix system, and I'm unpacking files and I'm putting them in /temp. And my risk is that somebody is going to have a race condition in /temp. Why don't we just move the unpacking to a private directory where that can't happen at all? And then we don't have to get into a risk quantification exercise. We don't have a compensating control. We've got a redesign. And we avoid the problem and we avoid the argument altogether. And if you're threat modeling while the device is at the conceptual stage, that's really easy to do.
Good. So last step, that's the most complicated, I'd say. This is the one I have a hardest time thinking about. So did we do?
Yes. There's two big elements to the question of did we do a good job. The first is what I think of as mechanics. Did we draw the diagram? Does the diagram reflect what the product is? Did we make a list of threats? Do we have an appropriate number of threats that is aligned with the procedure? Did we track all of them? Are they all in the quality system records? I think of all of that as mechanical elements of did we do a good job? And I think they're tremendously important, but I don't actually think they're as important as the next piece, which is, are the people who did the threat modeling work happy? Because everyone in the world satisfices, right? They pick an amount of work to do that gets the job done and then they stop. Because there's something else to be done that's more fun. Take this, the first hour is great, we find a lot of problems, but then I've got to spend 10 hours building out this fancy diagram and making it colored in these ways, and that doesn't feel like a good use of my time. They're not going to do as much of that work. And so making sure that the participants find it valuable is really important. And one of the challenges that people often face is in risk quantification, right? We're told to use CVSS or some other system, and we're told to put numbers onto the impacts. And it's a source of a lot of contentious argument. And right now, that's what the guidance says. That's what some of these standards say to do. And so I don't want to
Change it. What would you change it to?
So the first thing I would do is I would ask a standards body, NIST, AAMI, FDA, HSCC. I'm not saying a specific body must do this work, but let's publish some tables of acceptable answers to these questions, right? If the work is contentious because we don't have the data to really answer what these impacts are, why don't we just agree that a certain set of okay numbers, some ranges, some default values, right? Unless there's a reason not to use this value, and such reasons might be A, B, or C, you can use the number 35 here, right? And we might not love the number 35 for whatever this is, but if I, as the engineer, and you as the quality system person, have nothing that works better than 35 and no reason to change it, and we can cut out hours of argument and research because there's no good answer, let's just use 35 and save everyone a whole lot of time. And let's say 0.35 is the probability that someone is going to click on a phishing email or need a password reset. Next year, and I'm just going to pick on AAMI here, I'm going to say AAMI can say 35 is no longer accurate, it's now 75. Please go update your threat models to reflect changes in the threat landscape. And people can go plug that 0.75 into their models and see what it means. And because we're doing the work once, we can reduce the overhead across industry. We can improve consistency. We can admit that nobody likes that 3.5 or 7.5 or whatever it is, but that doesn't mean we can do any better than it. But actually, what I'd really like is I'd like FDA to say, we think it's okay to put this number in this place when there isn't good data. Because I think that would help us go back to your question about how do we say, did we do a good job? We could say, we don't love this number, but we have no way of really improving this number today. And so this number is an acceptable engineering kludge that we think is as good as we can likely do for all of the downside. And then the team can spend their time on other work, right? They can write more saying in the medical device world, they can write more unit tests. They can improve the user manual. They can drive down the cost of goods sold so that the device is more accessible to more patients.
And it's less risky for medical device manufacturers that don't necessarily know what they're facing. So this is an uncertainty less. So Adam, recapping for the last piece of the link two. We have two questions to answer. First, look over your work. And second, make sure that you have to align the keys. How would you simply?
Sure. No, thank you. I hope your listeners have fun with that answer, but to make it really concrete, I actually ask, would you recommend threat modeling to a colleague? And usually, as we're starting out with an organization, the answer is yes, because it's a requirement. Or outside of the medical device world, they're like, no. It took too long. I don't feel like I got enough value. I didn't feel like we had the right people in the room. They have objections. Giving people a chance to voice those objections is the beginning of a quality improvement process.
Okay, so it's also about collecting feedback for the next standing threat model.
Yeah, and really asking about people's satisfaction is one of those things that can be ritualized and ignored, or we can really lean into it. And I really want to encourage your listeners to lean in. I want to encourage your managers, your executives to lean in, because any new thing you're learning to do, you have to practice before you're good at it. The first time's going to be uncomfortable, and that's okay. You got to get back on the horse. We're in a medical situation. You have to try it on the next patient. You have to do it again and again until you become good.
And so what if it was one of those managers wishes, I want to do threat modeling, I want to do it responsibly, how would you advise them just to?
Well, I would start by doing, right? Ask, what are we working on? What can go wrong? What are we going to do about it? Did we do a good job? We've got resources like the playbook. There are consultancies who will help you, who can talk about how the FDA will look at your answers, who help companies. By the way, mine is not one of them. We do a lot of training. If you want training, come talk to us. But get started. Give it a shot and focus on, did we do a good job? What are we going to do differently next time? Because there's no time like today to get started.
Oh, beautiful, Adam. Thank you very much for this information. You're an author. You wrote 2 books, and if people want to find out more about you, where should?
So Shostack.org has information about my books, which include Threat Modeling Designing for Security and Threats, What Every Engineer Should Learn from Star Wars. It has information about our Magic Security Dust, or those of you who don't want to spend a lot of time on threat modeling. And lots, it's got training, all the other stuff. So yeah, check out showstack.org.
Yeah, you'll see Adam has a beautiful way of writing that's very easy to read, fun as well. So
Thank you.
thank you very much, Adam.
Thank you.
All right, folks, here are the top 3 learnings that we've had from this episode. Number 1, threat modeling is built on simple questions. What are we working on? What can go wrong? What are we going to do about it? And did we do a good job? These questions should be asked early in development when changes are easier to make. Number 2 is all about visibility. Diagrams are crucial for getting everyone on the same page. But you don't have to do this massive project. You can start simple. Start with a simple whiteboard sketch that can provide great value before moving to something more formal and documented diagrams. Number 3, focus on practical solutions rather than getting stuck on perfect risk quantification. Think before you do. Sometimes redesigning to avoid problems entirely is better than trying to calculate and mitigate specific risks. Oh, one more thing before you go. To apply this knowledge into your organization, I highly recommend subscribing to my newsletter, The Cyber Doctor Notes. It gives you weekly advice on how to make amazingly secure medical devices. The link is in the description. I'll see you next week.